history. Examining patient really is mainly actually, you could see patient when they walk to the clinic, they have very funny actually gaits, they waddling gait, and they have excessive lumbar lordosis. In some, especially male, they have floppy tongue, and their speech it could be muffled. And when you see them getting out of their chairs, they may not, they need their hand to support. And if you ask them to lie down on a flat surface, they may need to use Gauss maneuvers to get up. So these are the sort of things, and we would be looking at. By and large, even though it's neuromuscular, it is a really cranial nerves and other neurological examination, and usually well preserved. So who should we test for late onset Pompe disease? And I think this is really an interesting question, and usually there's no really right answer. I think given the fact the tests are simple blood enzyme analysis could give you the diagnosis, one would say all patients with proximal or limb girdle muscle weakness, because we have a lot of patients who were referred to us with limb girdle or referred to the neurologist and turns out to have Pompe disease. Of course, this patient, they said, well, if I was picked up, say, 7 years ago, I would have actually have after enzyme replacement treatment for 7 years. And there are people who do still feel resentful about the delayed diagnosis, and it's very common in Pompe, the late onset form. And all patients with myopathy prior to biopsy in theory, but the neurologists, they tend to have easy access to muscle biopsy, but most of our patients would have had a biopsy before actually had their enzyme analysis. Of course, biopsy may not give you also the right diagnosis, and sometimes you could have inconclusive result. And someone with unexplained respiratory muscle weakness or difficult to wean them off from ventilator, for example, especially if they have any proximal myopathy, as long as you rule out intensive care induced myopathy, then you should be looking at testing them for Pompe disease. And in terms of tests, we can do dry blood spot, which is actually simple, fast, and most industries involved in enzyme replacement therapy do provide this free of charge. For whole blood lymphocyte analysis would give you reliable result. As I said, muscle biopsies are usually commonly done, but we could avoid that by doing the enzyme analysis. I think nowadays we don't really do fibroblasts because it does require up to 6 weeks to grow cells. And the other diagnostic tests that nowadays, when we are going through the genomic project, I think mutation analysis is important because for some lysosomal storage disorders, we have to look at their mutation to determine whether they have a amenable mutation for treatment. I think we haven't reached Pompe yet, but one would hope we would be following that pathway. Of course, the other thing also would help you to phenotype genotype study, because now we know one spectrum infant would die before the age of 1. We could have adults who live to old age, so there are a lot of patients in between. We could do for care testing and prenatal diagnosis can easily be achieved by mutation analysis. Muscle enzyme could be slightly raised, but it's not diagnostic. Of course, once the diagnosis is made, we have to assess the disease burden to determine whether actual effective treatment would be possible. So one of the things we do in our setup, we do quantitative muscle test. And as I alluded earlier on, not every muscles are involved. And MRI, MRS can give you some information about the state of the muscle, but most of the time patients, they don't lie flat easily, and it's usually challenging. And these are also motor function tests, especially specific for Pompe evaluation of disability inventories, and function motor testing, time test, arm and leg functional test. These are the sorts of things be used actually to monitor treatment. Of course, the other area of interest would be the respiratory muscle, because the diaphragm is one of the muscles which is involved early on. Normal spirometry test does not give you actually the full assessment of the respiratory muscle involvement, because it's mainly designed for chronic obstructive airway disease. But really what we need to do, the mouth pressure, especially measuring maximal inspiratory and expiratory pressure, and the simple sniff pressure could also give you actually how the level of the respiratory muscle involvement. In this case, of course, we can do sleep studies in arterial blood gas. When it comes to the disease-modifying therapy, we have at the moment 2 licensed enzyme replacement therapy, and one is going through the appraisal process. So essentially, by sometime next year, we'll have 3 enzymes as a disease-modifying. This is, I think the basic principle is more an accidental finding of cell-correcting one cells with lysosomal storage disorder, MPS1 correcting another cells with lysosomal storage disorder, MPS2. When they are mixed together, essentially the cells morphologically become different, and then they start looking what actually led to this. And essentially one cell corrected the others, they both actually became normal. So the other interesting part for lysosomal distant proteins, they need to actually, like any other protein, they need to undergo protein modification, and especially they need to be tagged with mannose-6-phosphate. And the lysosomes have mannose-6-phosphate receptor, and then they could actually get to the lysosomes and work in the acidic milieu to break down. So really that's the concept. And the other advantage also, you only need a small amount. Correcting 1 to 2% would be sufficient to correct storage materials. Of course, that led to really, as I showed you early on, life survival in infantile form has improved drastically. But in this study, what they have shown, if you actually do newborn screening and look actually the difference, and for example, here is the survival rate. These are actually the comparators group. The green ones are newborn screened. They survived all of them. And those are actually the clinically treated group are the blue. And of course, these are the untreated cohort. And then again, the same when you look at actually their walking ability, and those children who weren't treated weren't able to walk, but those newborn screened, essentially almost all of them were able to walk. And those who were treated after a clinical diagnosis did a lot better than actual patients who weren't treated, but certainly a lot less than. It's the same also looking at the survival actually. So really, I think essentially newborn screening in this case is effective means of treating. It's a bit different for late onset. So this is really the pivotal study which they looked at the endurance assessment. There is an improvement of about 30 meters over actually the study period of 3 years. And there's a small improvement in respiratory muscle strength and lung volume. But of course, those historical patients who were on placebo deteriorated and the gap became wider. Those are the sort of things I think in infant it really is an effective treatment. And late onset, I think we think it will hold the progression, but it's debatable in terms of its effectiveness. So really, despite the treatment we have, patient may still progress. In mobility is the main things, in that on wheelchair, most of them. Most people require respiratory support. It could initially would be non-invasive, but some may require invasive ventilations, and bladder, bowel incontinence, swallowing difficulties, psychosocial issues are all this, despite the treatment we have. So in summary, Pompe disease is a progressive muscle weakness. and it can present at any age, and this the spectrum is enormous, but the same genetic defect. And the late onset Pompe disease, delaying diagnosis is very common, but of course now we've got a simple test to do that. Enzyme replacement therapy in infant, it has improved survival considerably, and of course we do use them as a standard of care for symptomatic adult Pompe patient, with the hope it will slow the progression. Of course, many patients do require respiratory support. So I think with that, I'll finish my talk. Thank you very much.